Thanks to all the audience who follows our broadcast. We are live on the second day of the 2020 International Web-Based Neurosurgery Congress. Remember, we are streaming on YouTube Live too. Today, we are pleased to welcome Dr. Hugues Duffau. Dr. Duffau is a well-known neurosurgeon from the University of Montpellier. He is professor and chairman of the Neurosurgery Department at the Montpellier University Medical Center and head of the ANSERM 1051 team, Plasticity of the Central Nervous System, Human Stem Cells, and Glial Tumors at the Institute for Neuroscience of Montpellier. Today, at the IWBNC, Dr. Duffau is going to share a lecture on early maximal safe resection in low-grade gliomas, a personalized connectome-based approach about more than 1,000 awake surgeries. Please type your questions in the Q&A section. We will read them after the end of Dr. Duffau's intervention. Welcome, Dr. Duffau, and thank you. Microphones are all yours.
Thank you so much for your kind invitation. I'm very happy to have this opportunity to present my results regarding, as you said, more than 1,000 awake procedures for low-grade glioma and to introduce the concept of a connectome-based approach. Indeed, in oncology now, the concept is to arrive earlier and to remove more tumor in order to increase the median survival, but also to improve the quality of life, which is particularly true for low-grade glioma patients because now I have more than 20 years of follow-up. And to be ambitious, we need first of all to arrive earlier and earlier. When the tumor is already very invasive, it's much more difficult to change radically the natural history of the disease. And this is the reason why, of course, I will tell you that wait and see attitude should be abandoned. Maximal resection too, if we can remove more, it's better regarding median survival, including by starting to introduce the concept of supratotal resection, of course, when functionally feasible. And then safe resection with intraoperative mapping, but also a better understanding of the connectome of this patient at that time. And this is the reason why I will introduce the concept of the meta-networking brain at the end of my talk in order to illustrate this magic potential of brain plasticity in our patients. I will not too much insist on the natural history of low-grade glioma. I'm sure now you know and you agree with the fact that unfortunately it's not a stable tumor and that this tumor will grow regularly, will diffuse within the white matter tract, but also will become malignant and finally will kill the patient if we are doing nothing. We know also that it's very important to be objective, not only regarding the oncological issues, but also for the cognitive issues. And this is the reason why for more than 15 years, we decided to do systematically an objective cognitive assessment in patients considered like young with a normal life. And in fact, most of the time they have already some degrees of deficit regarding the executive functions, the attentional processing, but also the emotional processing, the behavior, the personality, and so on. And in fact, these deficits before any treatment are not related to the lobar location of the tumor, but to the invasion of the white matter tracts, because you will see that the connectivity is the main limitation of this magic neuroplastic potential. And this is the reason why we have to be objective before to go to the operating theater and not just to say, this patient is able to talk and to move, so is well. We have also to burn the concept of localizationism, and I will insist many times about that during this talk. Nonetheless, the brain has some limitations, especially at the cortical level, and this is the reason why most of the time, especially in low-grade glioma, the diagnosis is made in because of seizures, which is finally the first level of limitation of neuroplastic potential. So regarding the oncological considerations, Mitch Berger demonstrated already 20 years ago, and we confirmed that in our low-grade glioma consortium in France with more than 1,500 patients, that if the tumor is bigger before any treatment, then the risk of malignant transformation and then the risk of death is higher. This is the reason why, once again, we have to arrive earlier and earlier. But we have also introduced the concept of kinetics of the tumor. So to do 2 MRIs before to go to the operating theater. Of course, we have not to wait 6 to 12 months, but just a few weeks. And if you do a volumetric assessment objectively of the FLAIR hyper signal, you will see that in 100% cases, this tumor is growing. And just by looking at the MRI is not enough. This is very important because, just an evidence, if the tumor is growing faster before any treatment, then the prognosis is worse, and the reverse is true. And what is very exciting is that this just common sense is much more reliable to predict the prognosis at the individual level than the molecular pattern of the tumor itself. In other words, you know the prognosis better before to go to the OR rather than by benefiting from the molecular profile. Typically, we demonstrated that you can have tumor growing very slowly before and after surgery, while they are IDH1 wild type, for instance. And this is very important because we published a series with a prospective collection of data in patients with low-grade glioma wild type. And you can see that I have more than 84% of survival after 6 to 7 years without adjuvant treatment, because the tumor was removed, of course, earlier, but also with a slow growth rate before any treatment. In other words, that means that more than 80% of cases, patients with wild type low-grade glioma following surgery, I do not speak about biopsy, of course, will benefit from a Stroop protocol following surgery for nothing. And then when we will need irradiation more than 10 years later, it will be impossible because radiotherapy has been performed systematically on basis only of molecular biology, which is just a part of the history. Speaking about surgery itself, you know probably these 2 very important series from Sweden and from Germany, demonstrating that very honestly, if you do just biopsy, the median survival is between 6 to 7 years, despite chemoradiotherapy. If you do a volumetric assessment, not only before surgery now, but after surgery, in order to be objective and not just to say, I'm a good surgeon, I removed the tumor, I know that. No, we have to show the postoperative FLAIR MRI and to calculate objectively. At that time, we changed radically the natural history of the disease because the median survival in our prospective series is more than 15 years, so the double. And this is true because we are doing, it's exactly what I will illustrate in my own experience too, more and more reoperation because my patients are still alive in the vast majority of cases after 10, 15, or even 20 years now. But I did not cure them, so I have to reoperate and to reduce again the volume without radiotherapy to preserve the quality of life thanks to mechanisms of neuroplasticity and to avoid malignant transformation. So the dilemma is solved if we are adapting our surgical strategy, not just now, but during the second surgical act, the third one, and so on, to the modification of the functional anatomy of this brain at that time, knowing that we have not a common brain. So we cannot just operate on the basic of localizationism. And we have no reason to do any biopsy, except in gliomatosis-like, which is very unusual in my experience, maybe 10% cases. Because if you do a biopsy, just to confirm that it's a low-grade glioma, but please send me the patient with 2 MRIs and I will demonstrate the growth rate and I will tell you this is a low-grade glioma, I don't need any biopsy because we will benefit from more molecular biology examination too by removing the lobe rather than to do just a sample because you know that you have a risk of undercotation. So if you remove more, you will really increase the median survival and the quality of life. It's not just a hope now, it's done with 20 years of follow-up. So the question is, why not to operate, especially in so-called eloquent areas? And the answer is, I don't know, because we have to do that earlier, but also to do a mapping for this patient at that time. Indeed, the vast majority of gliomas, especially low-grade glioma, are located within the so-called eloquent areas according to a localizationist account, like the SMA, the insula, the Wernicke, the Broca's, and so on. You can forget it, definitely, because the brain is not processing like this. And I will show you that based on results, but also based on a new concept in cognitive neuroscience. In other words, you can burn Broca Wernicke model. And I am French nonetheless, so you can say that. Of course, functional imaging is very important, and I am PhD in functional imaging. But nonetheless, I will tell you it's very important as a didactic tool. This is the reason why better the functional anatomy of the brain thanks to the use of intraoperative mapping, but also pre and post-operative functional imaging, but also for research, but not into the operating theater, because I will tell you a secret. Functional imaging at the individual level does not work. It's not possible to make the difference between critical areas and areas you can remove, and then to induce a transitory deficit, but the patient will recover, and finally you will increase the extent of realization, which is the goal, to allow the patient to continue to live longer. Second, because you can see the sensitivity and specificity for language. And voluntarily, I used for that series published elsewhere. So it's not me, I am totally objective, but we have exactly the same because we did the same for resting state. Once again, I am PhD in this field. So of course I love technological development and I am the first to use resting state, but to better understand brain processing, because if you compare resting state before surgery with patients with gliomas, with intraoperative cortical and subcortical mapping, the reliability is 85%, which is beautiful, but I will not take 15% of risk for my patient to keep a deficit or not to remove the tumor, because I have less than 1% of risk. So I cannot rely on that. And this is true, unfortunately, also for DTI. You know that DTI is not the anatomy. You know that DTI is not a function. And nonetheless, we will continue to put DTI into the neural navigator by telling this is the arcuate fascicle. No, this is just a reconstruction based on biomAthematics. And once again, the proof, not by my series, but by a very important paper published by experts in this field 3 years ago, and you can see what they concluded. The tractograms contain many more invalid than valid bundles. This is not my imagination. It was not 20 years ago. So that means that today you cannot rely on fMRI, resting state, and DTI. So you have just to wake the patient, because we have a chance to benefit from the truth in front of us because we are neurosurgeons. So if the patient is awake, you can do a real cognitive assessment online, not only before surgery, but in a sense, throughout the resection by doing intraoperative electrical mapping, both at the cortical level and at the level of the white matter tract, and then to better understand the connectivity of this patient at that time, and then to avoid any permanent deficit, because dealing with the mechanisms of neuroplasticity. What means quality of life? Of course, no hemiplegia, no aphasia. I did not induce any severe permanent neurological deficit, hemiplegia, aphasia for more than 10 years. I cannot lie. I have visitors more or less every week in my institute, except of course in this period. But I can tell you that it's not enough to be human beings, and especially when you will have the opportunity to live 10 to 20 years in front of you, and maybe more, because I will continue to follow patients. So you have to ask them what is absolutely crucial for you in your life in order to continue to build something original as a human being for the next 2 decades. And it depends on the patient, but also on the environment. For legal issues, if you have a menopia in France, you cannot drive. In some countries, in North Africa, you can. Cultural aspect. I cannot understand very well the neural basis of language if you speak ideographic language, like Chinese, for instance. Socioeconomical parameters. I will speak a lot about post-operative cognitive rehabilitation in order to push mechanisms of neuroplasticity after the first resection. But in many countries, you are not reimbursed, while in France you are. So in fact, I will induce more neuroplasticity in order to reoperate more patients without any problems regarding the quality of life, and then by increasing the median survival because my patients are rehabilitated, because you are in France, because you are reimbursed. So you see that we have to deal with so many parameters. So my protocol is that I have no protocol because I operate patients coming from 5 continents, and I have to adapt, and not only to French people. But first of all, I have to adapt to the brain of the patient, and you have to do the same thing. In other words, not just the cortical location, because the cortex is very plastic. If you remove Broca's area, I did that in more than 200 cases, never I am induced any severe permanent deficit. But if you cut the arcuate fascicle or the inferior fronto-occipital fascicle, you will induce permanent sequelae. So that means that we have to adapt to the connectivity in the depth. And finally, this is the reason why I have the regret to tell you that for 20 years, I do not use technology into my operating theater. No neuronavigation, no DTI, before and after, of course, to better understand mechanisms of neuroplasticity, like fMRI, as I said, but not into the operating theater. No ECOG, no intraoperative MRI, no microscope. You can do that with just a fork and a knife, a stimulator, a good team, and your knowledge of the functional anatomy. And never this kind of information will be available in a neural navigation system because the neural navigator doesn't know the principle of meta-networking brain because it continues to believe on localizationism. So it's wrong. An illustration. Many colleagues are telling me now, okay, we have understood if there is a tumor located within the so-called left dominant hemisphere, we will do a weight mapping in order to map language. No, you have understood nothing. Of course, that the right non-dominant hemisphere is critical for me to operate an insula, to write paper, or to give this kind of talk in front of a screen and not in front of you. My brain has to adapt. So I will change the interconnections between different networks, like language, switching from French to English, but also because I see a screen, so no empathy in front of me. So if it's true for me, it's true for my patients. The right so-called non-dominant hemisphere is critical for control of movement, spatial cognition, as you can see, but also social cognition, empathy, theory of mind, non-verbal semantics. Most of the time, we understand the world around us without any language. But also working memory, executive function, the multitasking, the ability to do many things simultaneously, and the behavior, the personality. And finally, you can say to a patient, I will control all these factors, all these parameters under general anesthesia by using MEPs and to avoid to be hemiplegic. And you think that it's enough. Please give the choice to the patient. And you will say, but it's not possible to control that, to monitor this kind of function into the OR. Of course it is. We are doing that for more than 10 years, and we validated these tasks involved in multitasking, working memory, semantic association tasks, so non-verbally, and emotion too. And what we discovered was just an evidence is that Broca's area does not exist speaking about language. Once again, you can remove in the vast majority of cases the pars opercularis and triangularis in the left so-called dominant hemisphere and right-handed patients without any problem if you preserve in the end your arcuate fascicle and the I4. Otherwise, of course, the patient will be aphasic, related to the fact that you got the connectivity, which is the limitation of neuroplasticity. So you have to understand in your mental imagery this kind of diagram you have in addition to the information provided by the patient into the OR. And of course, you can adapt also to the quality of life redefined by the patient. You are a dancer in the right non-dominant hemisphere. You need absolutely to avoid the neglect and then to do a line bisection task. And you are a writer, you have to preserve the syntax. or mathematician the calculation. So you see, it's in addition to, and of course, they are not hemiplegic, aphasic, but this is not enough. And the most important, and I was the first to miss that during my first 10 years, is the emotion, because we are human beings. So that means that, first of all, we are emotion. You cannot accept or not. This is the reality. So we have to ask to the human being in front of us, do you want to take the risk to change your personality or not? And if he's telling you, I want to live more, I want really that you perform supratotal resection, and if I am not hemiplegic, I'm happy, okay, you push more. But if the patient is telling you, I am 25, I want really to build a normal life and to get married and so on, I don't want to change my behavior, you have to wake, even in the right frontal lobe, by telling, I will monitor, thanks to our psychologist, behavior, theory of mind, mentalizing into the OR. And of course, it's possible. And not only at the cortical level, once again, this is the easiest way because the cortex is very plastic, but at the level of the white matter tract. So very easily, if you cut the pyramidal pathway, of course, the patient will be hemiplegic. Everyone knows that. I will not insist. But now think about this concept we will apply to other functions. The negative motor area. If you are a surgeon, if you are a pianist, if you want to do sport, you need bimanual coordination. And it's not just, I am hemiplegic, yes, no. So you have networks involved in the control of very fine movement. We published this map in Brain Pasture. But you have connectivity, and especially the frontostriatal tract. And when you will stimulate in the depth, you will induce an arrest of movement. And of course, I can cut it, and the patient will recover, will not be hemiplegic, but he will not completely recover. 3 days ago, I met a patient I operated on 15 years ago. Then 7 years ago, no chemo, no radiotherapy. So you see it in the SMA. But she told me I was a dancer, and to be honest, since you operated me, because I didn't know that 15 years ago, I cannot dance normally. You can say, oh, you're happy, you have a job, you can drive, no chemo, no radiotherapy, no epilepsy, everything is perfect. No, she has to decide. And 15 years ago, it was impossible to give this choice because we didn't know the neural network involved in motor control. But today, we have to know. Then you have to give the choice to the patient. And of course, the motor network is nothing without the somatosensory feedback. Everyone knows that when you stimulate, you will induce tingling, but it's not enough. There is no only perception, somatosensory perception, but also somatosensory awareness of your own body, which is absolutely crucial if you want to run, for instance, a marathon. But I have many patients able to run the marathon following surgery. So we published in Brain recently, be careful about the consciousness of your body shame. Visual pathway, I will not insist, I spoke about that before. Of course, if you induce a permanent hemianoptia, you cannot drive. You can say, my patient is well, he's able to move and to speak. No, if he cannot drive, maybe he can lose his job. And this is the same principle regarding the spatial cognition. In order to avoid hemi neglect, we have to preserve the cortex, but also the SLF2, the lateral, the middle part, part 2 of the superior longitudinal fascicle in the so-called right nondominant hemisphere by doing a line bisection task. And once again, every patient will not tell you, I need absolutely to preserve this function. But some of them, yes, if you don't give the choice to them before surgery, they will be disappointed after that. Regarding language, I'm sure you know that there is dorsal pathway with phonological and articulatory involvement, but 90% of neurosurgeons I know today have not accepted or understood that the pars supercularis of the inferior frontal gyrus, the so-called Broca's area, is not directly connected to the Wernicke's area, but connected to the posterior part of T2 and T3. It's not my imagination, it's DTI and dissection. Please go to the lab, do the dissection by yourself, and you will say, oh, there are some fibers in T1. Yes, but the vast majority is T2 and T3 in agreement with the new model of language proposed in the literature based on neuroscience. This is the reason why we have to be neuroscientists. On the other hand, for a long time, the ventral semantic pathway was neglected. And now we have understood that it's maybe the major inferior fascicle in the human brain that existing in a chimpanzee. And it's very important, not only for language semantics, but also non-verbal semantics. Third, the inferior longitudinal fascicle. If you cut the anterior part, you will induce lexical access disorders. We published that recently in Brain. Posteriorly, reading disorders. You will tell me I can live with an increase of reaction time regarding the lexical access. It's exactly what happened to me when I speak English in comparison with French. But I have not to decide for the patient if he can tolerate that or not. I have just to expose. And if he's telling me I don't want to have any increase of the reaction time, at least, of course, beyond 3 months after a transitory worsening and rehabilitation, then I have to stop earlier. Fortunately, the brain is magic, is able to compensate our mistake. And this is the reason why we can really introduce the concept of neuroplasticity, which is not one area compensating another area, but which is a subnetwork compensating another subnetwork. In this example, the inferior longitudinal fascicle in its anterior part, plus eventually the uncinate fascicle, can be compensated by the inferior fronto-occipital fascicle, and maybe you will have a slight increase of reaction time, but everything will be okay. So we have to discuss with the patient before what he can tolerate. Speaking about the IFOF again, I say that it was involved not only in verbal, but also non-verbal semantics. It's much more. It's involved in what we call the metacognition. Knowing of knowing. Is it possible for me to be aware about the fact what I know, what I don't know? And if you want to build a life for the next 20 years, you need that. So you imagine your patient, they need that also. Otherwise, they are not really human beings. So if you cut the IFOF, they will have problems, even if they can speak. But I have the regret to tell you that it's true for the right IFOF, you know, in the so-called non-dominant hemisphere. And of course, when you will meet a patient just after surgery, you will say, are you okay? Can you move? Can you give me your name? You will say, you see, I did the surgery under general anesthesia, and my patient is able to name, is able to move. Yes, but your patient will not return to a normal life by having the capacity to anticipate what they would like to do for the next 10 to 20 years. And then it's really a problem also for the emotional processing. Is it possible to map and monitor the theory of mind, the perception of intentions of others? Yes, it's possible into the operating theater. It's true at the level of the cortex, once again, very plastic, but it's true at the level of the connectivity, which is the limitation of neuroplasticity, speaking about mentalizing, and especially the right inferior fronto-occipital fascicle. So how is it possible to perform surgery in the right hemisphere under general anesthesia? Because you can see a very simplistic model we published recently regarding the processing within the right hemisphere. Speaking about nonverbal semantics, mentalizing, spatial awareness, and so on and so on. You have understood. How do you want to be sure just by using MEPs, just to avoid hemiplegia? So you have to be honest with the patient. I will avoid hemiplegia, but I'm not sure that you will be human being anymore. My results. Otherwise, I can say what I want. If I have no proof, you will not believe me, but I have proof. I did more than 800 surgery in patients with low-grade glioma. So more than 1,000 awake surgeries, because I did more and more second, third surgery, because the vast majority of my patients are still alive and I cannot cure them. And of course, including in so-called eloquent areas, you can see on the slide, Broca's, Wernicke, behind the labia vein, and the corpus callosum, and so on and so on. Mortality, 0. 0.5% of severe permanent deficit, 2 strokes. But finally, There is zero, does not exist. We have to be humble. But more than 99% of patients had no severe neurological deficit. But what is beautiful is that despite the fact that we removed more tumor, 30% of patients improved according to an objective neuropsychological examination performed 3 to 6 months following surgery, and of course, once again, after cognitive rehabilitation, plus 80% of impact on epilepsy. And this impact will be more important if you can remove more tumors, because in fact, the epilepsy in low-grade glioma, it's not related to the core of the tumor, but to the periphery. So more you remove, more you will decrease the risk of malignant transformation, so increase the overall survival, but also to avoid epilepsy, so to improve the quality of life. And it's true in Montpellier or in San Francisco, you know, probably this meta-analysis, the goal was to say in the literature in general, if we use intraoperative mapping, the results are better. And we can confirm that everywhere in the world. And once again, without any technology. If you have technology in addition to, perfect, but use it in order to do cognitive neuroscience into the operating theater. Because 90% of people continues to believe on the fact that there is one area corresponding to speech output and one area corresponding to understanding, an arrow just in between, and that's it. No, we have to stop now. To map this neuroplasticity, functional imaging is very important, because even if it's not the absolute truth, you can repeat it before and after surgery, but also before and after rehabilitation, before and after a second surgery, and so on and so on. And by doing that, of course, you can see that there was a reorganization within the connectome, and not just one area compensating another one, but the use of both hemispheres in order to compensate, for instance, a supplementary motor area after a transitory syndrome, even if, once again, the patient will not totally recover regarding the very complex bimanual coordination. So we started to do that regarding movement initially by telling, I will come back a few years later, and in the meantime, the patient will continue to enjoy normal life, and he benefited from post-operative rehabilitation and so on. Okay, and then a few years later, you come back and the map changed. So you understand why it's not possible to use a template for one unique brain from one patient to another one, because they have not the same brain, but over time, over years, the brain of this patient will change also. And it's true for movement, but it's true for language. And very recently, we used fMRI in patients after surgery within the so-called left dominant hemisphere to start. And we did naming before and after surgery, and we correlated the two, you can see by yourself, the modification of the connectivity within both hemispheres, explaining why my patients are well. And of course, more you will have this information before to go to the operating theater, how the brain remapped before to have epilepsy, then more you will anticipate if you can push the resection or not, at least regarding the cortex, and once again, by preserving the main pathways we have seen in the depth. So now we can use this concept to remove the Wernicke's area. You have seen that sometimes I have not so beautiful post-operative MRI, but it's not against the median survival of the patient, because I will come back and I will remove more, and not against the quality of life. And without radiotherapy in the meantime, of course, otherwise radiotherapy will burn the connectivity, the limitation of neuroplasticity. It's true for Broca's area too. I was not able to remove completely the tumor during the first surgery, because sometimes the pars opercularis nonetheless can induce some language transitory disorders when you stimulate. But okay, I will stop now. I remove enough, no chemo, no radiotherapy, and I will come back after rehabilitation. Is exactly what we did. And this is the reason why our patients are living longer and longer. But we can go beyond. We can preserve also the metacognition by doing a bilateral frontal lobectomy, which seems crazy. This patient enjoying normal life, able to drive with a normal cognition, taking care of his family, working full time, blah, blah. But I did that in 2 times with 10 years between the first and second surgery, thanks to mechanisms of neuroplasticity, including not only movement and language, but also behavior and cognition. And once again, to incorporate more tasks into the operating theater means for many neurosurgeons, you will not remove enough tumor. But this is the reverse, because now we are going to speak about the concept of supratotalization, and you can see my prospective collection of data. The median survival is more than 16 years. 25% of my patients still alive with more than 20 years of follow-up after the first surgery. So it's not against the externalization and median survival. Indeed, I'm not afraid in the brain because my patients are awake, because I know the preoperative reorganization and neuropsychological examination. So I can use this knowledge in order to do wake mapping and to push the resection until functional boundaries at the level of the connectome of this patient at that time, and then to remove more tumor. And in the subgroup of supratotalization with more than 10 to 15 years now of follow-up, the rate of death is 0. I don't say that I cure them, but I say that I avoided malignant transformation. And it was the goal because it's not against the quality of life. So you will tell me, yes, but we have to arrive earlier in order to do supratotalization. Yes. So why to wait? No wait and see anymore. But we can also operate earlier and earlier in patients with incidental diffuse low-grade glioma. Why? Because they are not so well. Once again, they give you the feeling to be well, but do a cognitive assessment before any treatment. You will see that in 60% of cases, they have modification of cognition and behavior. Second, because in incidental diffuse low-grade glioma, you can have a sudden explosion in glioblastoma, like in this case. Unfortunately, this patient was referred to me while it was a glioblastoma in a patient without any symptoms. And they told me, can you operate? Of course, but it's a glioblastoma now. While if I had the opportunity to meet a patient since the diagnosis, I can tell you that I would be able to remove completely and even supratotally this small flare. And the patient would be still alive today. So in fact, we killed the patient by doing nothing and just by telling it's too dangerous to operate the brain. No, it's not dangerous. The tumor is dangerous. It's not dangerous if we know the brain. To prove that, I did more than 100 surgeries now in patients with incidental discovery of low-grade glioma. The rate of permanent deficit is 0. The rate of permanent epilepsy is 0. The rate of total resection is 30%, plus 30% of supratotal resection, no partial resection. So I changed radically the natural history of the disease. You will tell me it was just a low-grade glioma. No, in 30% cases, we identify some foci of malignant transformation in the middle. So no chemo, no radiotherapy because supratotal resection. And what about the return to work? We published recently in Neurosurgery this year, more than 97% of these patients return to work. And of course, with, as you can see, more than 95% of patients still alive with 6 to 7 years in this subgroup without chemoradiotherapy. So we propose to do a screening in front of the French National Academy of Medicine, and they say, yes. But you can do that with 99% of reliability only if you know the minimal common brain. I say that we have not the same brain, but we have the same skeleton, if I can say, within the brain. If you get it, arcuate, pyramidal pathways, IFOF, and so on, you will induce permanent deficit. So we published an atlas of brain plasticity. And finally, no one was very excited by that because the neuronavigator doesn't know this atlas. Why it's important? Because I can tell you that if you cut the connectivity in one hemisphere plus the other one, in mirror connectivity, you will induce permanent deficit. And sometimes you have to do that if you would like to remove more diffusion of the tumor. It's a diffuse glioma. So no, don't do that. Do chemotherapy. Yes, but it was not 1p92 codulated. I don't care. I think about the brain of the patient first. And in 50% cases, you will see nonetheless a shrinkage. And then you will be able to reoperate by leaving the contralateral connectivity intact because shrinkage induced by temozolomide independently of the molecular profile. Example, it's not a 1p9EQ deleted tumor. I did the first partial surgery, chemotherapy, shrinkage, second surgery, plasticity. 10 seizures a day before surgery, no seizures anymore, improvement of the quality of life. For many years, the patient can thrive. So do not rely at the molecular biology at the individual level. Everyone would like to irradiate, but it has been demonstrated that if you do early radiotherapy, you will not change the median survival. It's not my imagination. It was published by Lancet. But on the other hand, with more than 5 years, you will see a decline of cognitive function. And we are not speaking about patients with glioblastoma and median survival 1 to 2 years. We are speaking about patients living 15 to 20 years. So we have to anticipate for them. Indeed, the problem is that if your surgeon cut the connectivity, the patient will not recover. But if radiotherapists irradiate the connectivity, the patient will have a decline of cognitive function. They're telling, no, of course. Please do cognitive assessment 5 to 10 years later. You will see the decline. If the patient is happy, okay, but you have to give him also the choice before to irradiate according to the protocol based just on molecular biology. And even in the RTC, they said finally recently that they would like to consider with Monica Egi, I was not in the list of the author, to defer radiotherapy for preservation of cognitive function and quality of life. Oh, really? You have the feeling to read the paper by Duffau, but we needed 2018 to understand that. So we did not wait 20 years for that. And 20 years ago, we started to say, if we can remove more, it's better. We will stop according to the functional connectome. And then we will induce plasticity. Then we will come back. If there is too much diffusion, we will use chemotherapy, which is not at the origin of cognitive disorders. And finally, we will reoperate. And finally, one day, of course, we will irradiate, but in my experience, between 10 to 15 years, explaining why also the patients are living longer. But the first 10 years, they have a perfect normal life. Once again, you can see the survival with patients selected with my oncologist also. So that means that you can use the Glioma Network in France, my surgical series, the series by my oncologist, and so on and so on. They are not the same patients. In all cases, you are around 16 years, not 6. And I will be a little bit more provocative because we published this paper in Neurology just 2 months ago. If you have foci of malignant transformation, including glioblastoma in the middle of the tumor, just in the middle, because it was a low-grade glioma initially and you did an extensive resection, please don't perform systematically chemoradiotherapy. And by doing that, which seems to be a crime, you can see 5 years survival rate, 95%. Of course, remove the tumor earlier and we'll find more and more foci of malignant transformation. An example, you can see the real enhancement, 22. I did a very extensive resection, no chemo, no radiotherapy. Well, of course, it was a grade 3 in the middle. I redo a second surgery 3 years ago. And at that time, the neuropathology said, low-grade glioma. Of course, I removed the focus of malignant transformation 15 years ago. And now the patient is still alive with no chemo, no radiotherapy. So you see that it's not just one case. I'm speaking about hundreds of cases, but you have very beautiful illustration if you can do the resection according to the connectome of this patient. Forget the tumor. You will change radically natural history of the disease if you are doing an early and extensive resection. Please stop according to the connectome, and to do that, you need first of all to be a neuroscientist because we are doing intraoperative mapping. So you can publish in Nature, or recently in Neuroimage, we published the sole atlas in the literature with the critical networks, cortically, subcortically speaking, about 16 functional domains, language, movement, control, executive function, mentalizing, and so on, about almost 2,000 stimulation sites. this is an atlas you can use, probabilistic map. You can use because in a MNI template. And introducing the last concept before to conclude, the meta-networking brain. Networks of network. Do not believe that Broca's area is the area of language, at least speech, because you have a network. But in this network, you have sub-networks, dorsal pathway with phonological articulatory processing, ventral pathway. Okay, we spoke about that. But now we have to combine these different networks in order to adapt to the environment. I mean, you need to sometimes speak, switch, be focused, move, and to do everything simultaneously. And then you will recruit different, not subnetwork, but networks constituted by subnetworks constituted by a mosaic of cortical areas in order to solve a problem. For instance, suddenly, if I heard an alarm fire, and then I will have to adapt emotionally and also speaking about my behavior by creating a unique network, meta network at that time, transitorily, or eventually permanently if you decided to remember that. Why it's important? Because when you stimulate, I know that 99% of people, even I have trained, when they induce a transitory deficit by putting the probe at the level of the cortex, would like to believe on the fact that the area inducing a transient aphasia, for instance, is the area of this function. They're wrong. In fact, you disrupt a network, but you can disrupt multiple networks. And this is the reason why it's absolutely critical to ask a patient to do every 4 seconds into the operating theater at least 2 tasks, multitasking, and to move and to speak, to name, for instance, is not 1 + 1. It's much more because you need executive function, especially for 1 to 2 hours. And when you stimulate, sometimes you will see that you can block, of course, movement and language, but sometimes just movement, sometimes just language, and sometimes no language or movement. But the patient is not able to do 2 things simultaneously. So that means that if you continue, now you know that you will not be aphasic hemiplegic, but you will not be able to do 2 things simultaneously, so it will not be able to work again. So you have to be honest with the patient and the family before surgery by telling, I need to know more about the natural history of your tumor before to go to the OR by doing volumetric assessment, calculation of growth rate, and so on and so on. But into the OR, you have to talk to the brain. At that time, you have to forget the glioma. The glioma does not exist. It's a diffusion of tumor cells. So remove the parenchyma as much as you can according to the limitation of neuroplasticity in the patient at the time. And never, once again, technology, at least in this area, will give you this kind of information. So you have to see the pathways in your mental imagery by doing dissection, by using DTI before and after as a didactic tool, but also to build this network in your own 3D imagery in order to avoid to be addict of the technology. Otherwise, never you will obtain this kind of results. So now you have the choice. You can treat the tumor as a brain neuro-oncologist or to take care of a human being as a medical doctor involved in cognitive neuroscience, able to propose new model of cognition in agreement with the truth, but also allowing the patient to live longer and better. So if I can do that, you can do that. Good luck. Thank you. And I don't know if I am on time, maybe a little bit longer, 5 more minutes.
For you're perfect. Thank you very much for such a wonderful lecture, as you always do. I'm sure all the audience has learned from your robust experience. Right now, we have a few questions from the public. I'm going to read those questions to you. Georgios Miliaras is asking, how do discrepancy between tumor kinetic and molecular grading can be explained?
I can explain the fact that today the molecular biology is not the molecular biology. We have IDH1, 1P, and IEQ, and a few other markers, while in fact the tumor is constituted by billions of markers. And we would like to explain everything with just 3 to 4 markers. So this is the reason why we are wrong at the individual level. And then it happens that the tumor is growing faster, while my neuropathologist is telling me, don't worry, no focus of Magellan transformation, and it's mutated and 1P 9EQ co-deleted. And I will say, no, the tumor is growing faster. So I'm sorry, but I am anxious. And the reverse. So it's just a part of the history. And today, neuro-oncologists would like to impose the fact that with 3 markers, we can predict the natural story of the disease for long-term follow-up and what will happen to the patient. And most of all, what will happen when we will give chemoradiotherapy is totally untrue, like DTI predicting function. And finally, we needed for DTI, I make a parallel, 20 years to have this kind of beautiful papers honestly performed by experts by telling, in fact, it does not work, really. So this is the same thing for molecular biology, except if you can do, of course, pangenomics systematically and to understand the equation, the weight between different parameters. But who is able to do that in the world today at the individual level? So, of course, use it, but it's just a part of the history.
Thank you, sir. Next question. Which is the average time of your surgeries?
So the first surgery is, of course, as soon as possible after a few weeks, weeks in order to meet the patient, weeks in order to explain what I explained to you, more or less, to the patient. That means that my first meeting is 1 to 2 hours. The weeks in order to do a second MRI, weeks to do a neuropsychological assessment, weeks in order to say to the patient, please try to avoid to work for the next 3 months in order to benefit from post-operative rehabilitation, and so on. Then after the first surgery, I will just follow in the vast majority of patients the residue, or nothing if I did a supratotal resection, and to calculate the growth rate. And then when I will do a second or a third surgery, it will depend on many parameters. First of all, is the tumor is growing fast or not following before and after surgery. And definitely if finally the tumor will recur just in 3 to 6 months, that means that this is not a low-grade glioma, but that means also that plasticity mechanisms will not be able to compensate. This is the reason why the vast majority of patients with glioblastoma have a deficit. It's not like low-grade glioma with a slow-growing tumor. If the tumor is growing very slowly, then I will come back when, first of all, if the patient will have seizures again, limitation of neuroplasticity. But more and more now, I try to avoid to wait new seizures a few years later. So it will be the volume of the tumor. I mean, now it has been demonstrated initially by Mitch Berger, but we confirmed about more than 1,000 low-grade gliomas. Is really exceptional to see Magellan transformation in a tumor growing slowly before to reach at least a threshold between 10 to 15 cc. So if the tumor is within this range in a patient, a few years later, enjoying normal life, I will say I would recommend to reoperate preventively. And fourth, probably the most important parameter, the diffusion of the tumor. If the tumor is growing very slowly, but invading this minimal common brain, the connectivity, the white matter tract, the arcuate, the IFOF, you can awake, you can know the functional anatomy, you will not remove more tumor if you want to preserve the quality of life. If the tumor is growing much more at the level of the cortex, the U fibers, then plasticity will be more efficient. In other words, and maybe also, to be honest, you can include the molecular pattern, for instance, if it's IDH1 wild type, I'm not completely crazy too. I will say to the patient, no radiotherapy, but we will do an MRI every 3 months and not every 6 months in order to be sure that the tumor will not grow too rapidly. So you see that you have a mosaic of information, but in the end, the patient will decide. And if you explain everything since the beginning to the patient, I can tell you that today I had a consultation. The patient told me, I think that 7 years after the first surgery, I started to have like auras. And you told me past time we were very close to 10 cc, no chemo radiotherapy. Probably you will tell me I have to reoperate you. It's exactly what I did. And he told me I am ready. I organized everything. We will reoperate in 15 days. So the patient will make his own management because he knows the functional anatomy of his brain, his quality of life in essence, but also natural history of the disease. I'm sorry about that, but better than the vast majority of young oncologists I know.
Thank you, sir. Next question. Is there any absolute contraindication such as delirium, dementia, or confusion to perform these procedures?
Contraindication, I'm sorry, to do what?
To perform, I guess, awake procedures. He asks if delirium, dementia, or confusion will be a contraindication, if there is any absolute contraindication.
Of course, you have to benefit from a perfect collaboration of the patient. But speaking about low-grade glioma, most of the time patients, as you know, between 20 and 50 years are enjoying normal life. It's not like a patient with a very big glioblastoma in the temporal lobe and already comatose. So that means that it's not a philosophical issue. It's you are well before, I would like to preserve perfectly the quality of life. So it's very exceptional for me to have a contraindication. The sole contraindication could be twice in my life due to anesthesiologists, and they are very good. This is the reason why never I will fight against. The patient had really morbidity, morbid obesity. And then you have a risk to do, like in Montpellier, awake asleep. And then because it was low-grade glioma, we say to these patients, first of all, save time, a few months, in order to lose weight. And then to go to the OR without any risk to have aspiration. Otherwise, you can kill the patient. And you remember the mortality, in my experience, is zero. It's not just because I know the brain. It's because I have a very good team. And sometimes we are trying to find new solutions also, speaking about anesthesiological issues. And third, I must be honest also, I have probably a bias of recruitment because you know that low-grade glioma are not so frequent, and nonetheless I'm doing this kind of surgery many times a week because they are coming from everywhere. So sometimes the bias is that you have patients in good neurological and general status who would like to preserve a perfect normal life in this philosophy. So that means that in 99.5% of cases, I will not contraindicate the surgery if they are motivated.
Thank you, sir. Next question. What do you consider extensive resection? Beyond the margins of the tumor, should that become the target? And if so, how much should be the margins extend?
I have to re-explain. The tumor, I don't care when I am into the OR. So extensive resection means into the contact of the connectome, the functional connectome, the neural networks, the limitation of the plasticity, the white matter tract, I don't know how to explain. I don't care the tumor. And if I removed only 85% of the tumor, because if I got more, I would have induced a permanent aphasia. Of course, I will not do that. If I can remove 150% of the tumor according to the preoperative flare, I will do that. But once again, it's not just during one procedure. You can come back if the patient enjoys a normal life thanks to postoperative rehabilitation. And then to push these functional boundaries, which limited your extentorization during the first surgery, but not during the second surgery. So forget the tumor into the OR. I will continue to say that. I do not feel the tumor. I'm not a surgeon. I do not use imaging to see the tumor. I'm not an oncologist. I'm just a neuroscientist removing the brain as much as I can, knowing that this brain is, of course, invaded by a chronic tumoral disease. It changed absolutely everything, but also my results, 99% of return to a normal life with more than 16 years of median survival. So please try to do that, knowing that, of course, I do that also in glioblastoma. I mean, if you can remove much more than the enhancement and the vast majority of the flare by doing lobectomy according to functional boundaries, please do that. And never I published that, but in glioblastoma may be selected by myself, but the median survival, you can believe or not, is 3 years. And why I never published that? Because sometimes I spoke about that with colleagues and they told me, you selected patients. And I answered, but I thought that as a medical doctor, I had to select the good indications in order to be helpful for patients in agreement with Hippocrates. So I do not apply a protocol.
Thank you, sir. Next question will be, what is your appreciation on the use of 5-ALA in low-grade glioma surgery?
In low-grade glioma, I cannot understand because I cannot understand already in high-grade glioma. Because as I told you, if I operate a glioblastoma, if I can remove more than the enhancement, I will. And then you will double the median survival. So forget the tumor. I don't know how to say that to your oncologist. Think about the brain. We are not operated on a tumor. We are operated on central nervous system of human beings.
Is it indicated to repeat the functional MRI and tractography after surgery? If so, how long should we wait to repeat them?
I have the habit more and more to do that immediately following surgery, thanks to resting state, which was not possible during the task-based functional imaging, because of course, when I induced, like you, supplementary motor area syndrome, it was impossible the day +1 to ask to the patient, please move, because in essence, it was not able. But now, thanks to resting state, I'm doing that systematically before, and then the day after surgery, and then 3 months after recovery. And then it depends on the natural history of the disease, but especially when I would like to reoperate a patient, because at that time, I will see if the connectomes change according to the postoperative status a few years later. And then it will be another argument to say to the patient, you are well, the tumor grew, but did not migrate too much within the connectivity. The connectome changed thanks to this new functional imaging in comparison with 5 years ago. I think really that I can reoperate you now with more than 95% chances to reach subtotal removal, at least without any risk, except the 1% off. So you see that it's much more to try to understand what I do. And this is the reason why, more philosophically, I would say, I do not understand why it's not done systematically, because I thought that as a surgeon of the brain, we will have all of us to try finally at the end of our career to understand what we did within the brain of patients, rather than to reproduce the same surgical act according to the microscope telling you, you have to remove the 5-ALA.
Thank you, sir. Next question. What is your opinion about the applicability and limitations of the exposed concepts in pediatric and adolescent patients?
Pediatrics, to be honest, is not my topic. I'm not a pediatric neurosurgeon. The diseases are totally different. It's very exceptional to find diffuse glioma, and most of the time, so you can remove more or less a ball. Nonetheless, in adolescent, I did that from 13, and it has been possible in all cases because we motivated the patient before, and because it was able to help us thanks to neuropsychologists and pediatric neuropsychologists. And the most important is not the age. The most important is the motivation of the patient, because sometimes you can have 35 to be perfectly in shape and to say, I'm too afraid to go to the OR. But the problem is not to be awake. The problem is to go to the OR while you have one. And this is the reason why sometimes it's easier to explain to adolescents, if I remove the lesion now, then I will protect you for the next future. Once again, under 10, I don't know.
It's okay, sir. Yeah, we're over scheduled time, but only if you want, you can keep answering some few questions, only if you want.
Thank you so much. I will. And I would like to congratulate you for this beautiful meeting. Also, it's a very great idea, and I hope it will be helpful for young people in the world by telling once again, this is the message. If you learn, if you save time to learn the brain, to do dissection, to use functional imaging, not into the OR, but for your mental imagery, to do regularly stimulation, not only for low grade, high grade, but cavernoma, epilepsy surgery within the brain, then you will build something unique now, the interface between cognitive neuroscience, neuroplasticity, connectome, meta-networking brain. It will be your generation, and so many implications in functional neurosurgery, including for the BCI, the restoration of the function of the brain. And if you can create this new field, which is just in the infancy, so you will really deserve to be neurosurgeons. So once again, good luck, but try really to believe on you based on your work, multimodal work. If you stay all day long into the operating theater, you will be a good virtuoso, but you will not be a musician, not an artist.
Thank you, sir.
Welcome.
Amazing words. So next question will be, how is the experience of your patients during awake craniotomy?
Please tell me again, because I had a noise in my office. I'm sorry.
No worries, sir.
Yeah.
How is the experience of your patients during awake craniotomy?
During awake craniotomy, the most important is to have a good team, allowing you to have more time. And then after the opening under a sleep phase, to have more or less 1 to 2 hours in front of you. And that means that in very big tumor, on the other hand, you have not to try to remove the tumor from inside to outside. Otherwise, the patient will be too tired, not motivated enough. And finally, it will be difficult for the patient to help you when you will reach the deep connectome boundaries. So that means that my secret, technically speaking now, is to disconnect the part of the lobe or the lobes in a paralimbic tumor, for instance, in order to identify very quickly the limitations in the depth and to put the patient under general anesthesia after 1 to 2 hours, because I know that I can finish to remove the lobe and to avoid any pain, especially at the level of the temporal lobe, for instance, because I will not be into the contact of the dura mater of the skull base of the patient under local anesthesia, because you don't need to be there while the patient is awake, because you know that this part of the brain is already disconnected and not functional anymore. So you see that you change your techniques. You have these relationships with the neuropsychologist stimulating the patient every 4 seconds. You had also a long preparation before surgery in order to keep this motivation, and you have no pain, explaining why. You can believe or not, but once again, it's difficult for me to lie because so many visitors every day, every surgery, at least for more than 15 years, the rate of aborted awake surgery, in my experience, about more than 1,000 is 1.
Thank you, sir. Next question will be, what functional MRI paradigm do you use?
Resting state now. Do not believe on tasks. And once again, when I was younger, when I was PhD, I say I would like to apply to my patients exactly what I did, but most of the time they did not perform the task as we could expect, especially for higher cognitive function, because you cannot validate the feedback, because the patient most of the time is not doing overt task. So resting state. And once again, you can do that even the day after surgery, even if the patient has a very severe transitory worsening. You don't need the patient to say, please move to, or please think about animals, and so on and so on. You have to say, think about nothing, do nothing, be at rest. And suddenly everything is really much more reliable, speaking about the methodology underlying the interpretation of the resting state fMRI. So in summary, in my experience now, we are not using tasks anymore for many years.
Thanks, sir. Is brain plasticity affected by age of the patient?
Yes, but it's not. We have a threshold beyond 50, no plasticity anymore. It's better to be young rather than to be old. But nonetheless, I did this kind of surgery until 72, speaking about low-grade glioma. And if the tumor grew slowly, if I did surgery according to the functional boundaries, the patient recovered thanks to post-operative rehabilitation. So it just related. And more you have brain plasticity before surgery because you are younger, more you will recover quickly. But you can also have, fortunately, brain plasticity beyond 60.
Thank you, sir. How many minutes of resting state do you acquire for your patients?
This is the good question. We did only 8, and for many years it was enough. But now, of course, we would like to monitor, to map, to discover more, especially regarding the interactions between systems and not just within system, the principle of meta-networking brain. And of course, we start to say, oh, it's too bad because it would have been better to have more than 10 minutes. So you see that, in fact, it depends on the question raised, but in prospective collection of data over years, you cannot ask all good questions since the beginning. So in other words, at least 8 if you can, and the most is the best. But you have now to deal not so much with the patient, of course, he will not stay for hours into the machine, but you have to deal with your neuroradiologist. So good luck.
Thank you, sir. Next question. What will be the period? How long do you wait for repeating a FLAIR sequence to determine tumor kinetics or rate of tumor growth prior to the first surgery?
It depends. In fact, once again, I have no protocol, including to my own protocol, as you see. I mean, if you have already a big tumor, 100 cc, you know that you have all risks to identify at least some foci of malignant transformation, at least microscopically speaking. I don't speak about, of course, enhancement. And even if it was an incidental discovery with this volume, it could happen. So I will say, we have to be careful. Probably I will have to operate you very quickly because the tumor is very big. So I would propose to have a second surgery within the next weeks. I mean, 3, 4, 6. If it's a very small tumor, incidental discovery, again, no seizures, and 10 cc in the prefrontal lobe. You have time, of course, to do neurocognitive assessment. You have time to convince the patient to do a supratotal resection because maybe in this case you can cure him with more than 15 years. In this case, I will wait for 3 months in order to demonstrate that there is objectively a growth, and then to say to the patient, you have to be operated on. It's not my view. It's because, as you can see, the volume is increasing. So now we can change radically natural history of the disease. So you see that I took 2 different examples, preventive or very big tumor. We have to do that more quickly. So definitely, I adapt to the patient. And sometimes they are telling me also I had seizures. They told me that I have a brain tumor, that you are an expert in this field. You can operate me. I agree. Please operate me as soon as you can. So you see that once again, in fine, the patient decides.
Thank you, sir. Do you think that epigenetic has a role in glioma patients' recovery?
I don't know. I'm not involved enough in the field of genetics. I know just that we have a beautiful data bank regarding the neuroepidemiology, probably the largest one in this department, thanks to my colleague, Dr. Baucher, in Europe. And we try to mix with so many factors, environmental factors, of course, also some molecular factors we benefit today, and nothing was significant. So probably there are some factors with epigenetic modification, probably related also in part to the environment. But we are too far to explain that, because really we have tried everything, and after 25 years, after 1,000 patients examined, a posteriori, we identified nothing.
Thank you, sir. Dr. Gabriel Vargas is asking, he's saying to you, thank you for your excellent talk. Remember your course in Bucaramanga. What is your approach if you have the so-called radiologic finding of gliomatosis cerebri?
First of all, I would like to thank very much Professor Vargas. And as I said, it was a very good time in Bucaramanga, in Colombia in general. Very good foods also, it's very important in order to stimulate your brain plasticity, very good discussions. And as we discussed with you also, I would like to push you in Colombia, but everywhere in the world, to have these interactions between cognitive neuroscience, to be PhD in functional neuroanatomy, in genetics, epigenetics, what you want, but to have really background, not just dedicated to surgery. And suddenly you will see that you will create something different. I don't know why. It's possible because the brain is beyond our imagination, but it's related to this meta-network. But we have to push this meta-network. So please continue also, because we had this extensive discussion with Professor Vargas. Now, regarding specifically your question, I'm sorry, I had a problem of executive function, but I do not remember the question itself.
Okay, sir, he was asking what to do on a patient with gliomatosis cerebri.
I will do only a biopsy in this case, because I know that I will not be able to cut this connectivity, in a sense, too widely invaded. So the limitation of neuroplasticity. And of course, we will not do radiotherapy since the beginning. Otherwise, you will have to irradiate the vast majority of the hemisphere, sometimes both hemispheres. And then you will see, in all cases, a decline of cognitive function. So our policy, and not just mine, because of course, the oncologists are very involved in the management of this kind of patient, because I'm not the first therapeutic option in gliomatosis, like just biopsy, temozolomide first to preserve the quality of life, and to hope at least a stabilization, sometimes a shrinkage. And if it works, to continue 1 to 2 years. Then to make a therapeutic pause, and to hope that when the tumor will regrow, it will be possible to re-administrate chemotherapy, and then finally to postpone the more or less panencephalic irradiation. So no surgery really in this specific setting, except if the patient has intractable seizures with an invasion of the temporal lobe, and especially mesiotemporal structures. And sometimes I did in this patient temporal lobectomy, classically, if I can say, not because I changed the natural history of the disease. I was very clear to the patient by telling I will remove maybe 25% of the volume, but just to improve the quality of life. And then it was a kind of functional neurosurgery.
Thank you, sir. Maybe one last question will be, do you use nuclear medicine with amino acid tracers to planning surgery?
No. I have not to comment, because in fact, I know that 90% of my patients coming from everywhere in the world. So this is the reason why I can have a panel also regarding the management of patients, not just surgically speaking. I can tell you that except in Belgium, in Switzerland and Germany, more or less no one is using this kind of methodology, at least in clinical routine, whatever the continent.
Well, thank you very much. On behalf of CIEN, I'd like to thank you again, Dr. Duffau. This has been a wonderful lecture. We are really grateful and honored for your participation in the 2020 IWBNC. More than 3,500 people were registered to this Congress from over 120 different countries, and almost 500 people were connected to your conference. You are more than welcome to stay tuned to watch more lectures from the other speakers. In a few minutes, we will have Dr. Nader Senai doing his lecture. As I told you, he was saying hi to you some minutes ago. His lecture will be tissue-based clinical trials for progressive brain tumors. To get the link for this upcoming conference, please follow the link pinned on the chat screen or check the agenda on our website, cnhus.com.
Thank you so much once again. And also, I don't want to bother him now, but say hello to Nader for me. But for younger people also connected now, please stay to listen to the talk by Nader, because he built something also unique in Phoenix, Arizona. We met regularly. He came to Montpellier. I went to Phoenix, and I know he's doing a very great job. But he's a little bit younger also, so he will tell you how to build this kind of program and to demonstrate when I told you, if I can do that, yeah, you can do that, that it's true, and not just in order to give you the moral at the end of the talk, but just because it's objective. So enjoy his talk, and thank you so much.
Professeur Duffau, au revoir. Je vous remercie.
Merci à vous. À bientôt. Au revoir.
Au revoir.
Vous êtes le bienvenu à Montpellier quand vous voulez, je confirme.
Merci, merci monsieur.